Hello, everyone. Welcome to the third session of the Million Hearts Learning Lab. My name is Alyssa Foley, and I will be the technical host for today's session. I just want to do a brief welcome as well as a technology refresh. So for today's call, there are three options for joining audio. One is through your computer. Uh, Another is to call in. So either you can have WebEx call you, or you can call using the I will call in steps. If you have any issues with audio, you can go to the top of your screen where it says audio and video and be able to play around with the settings. Today we will be utilizing the Q&A box. So on the left side of your screen, there should be a box that says Q&A. If it's not open, you can open it by clicking the arrow next to it. And you can put in any questions that you have for any of the panelists into the Q&A section. We will also be doing a live Q&A where we're posing questions to our panelists at the end of the session. So if your question doesn't get answered in text form, we may be holding it to be able to answer it later in the session. The chat box has been disabled, so we really want to have Q&A go into that Q&A feature. And a friendly reminder that today's event is being recorded, and in general, all attendee lines have been muted. So again, if you want to ask any questions or you're having any audio technical difficulties, please use that Q&A box and we will try to get to everyone's questions. Now I'm happy to turn things over to Judy.
And thank you, Alyssa. And good afternoon. I'm Judy Hannon, the Senior Advisor for the Million Hearts Initiative. And on behalf of Million Hearts and my colleagues from CDC, from NACHC, from Johns Hopkins, from AMA, I just want to thank you for your interest in today's topic. But more importantly, for your attention to implementing the strategies you are going to be hearing about today. I'm going to turn it over to Fatima Coronado. She is our Associate Director for Science here at the Division for Heart Disease and Stroke Prevention at CDC. She's going to share some data behind our focus areas, describe Million Hearts 2027, and kick off a review of strategies we believe can make a difference in reducing disparities. I look forward to answering some of your questions when we get to the Q&A. And with that, Fatima, you're on mute.
There you go. Thanks, Judy, and welcome everyone. Can you hear me? Great. What a day. So let's talk about cardiovascular disease. CVD and the risk factors are experiencing disproportionately affected throughout the US population based on race, ethnicity, social factors, geography. Oh, next slide, please. During the pre-work recording, you heard about the racial disparities in hypertension. Not only Black persons develop high blood pressure at younger ages, they also have higher burden of hypertension and show significant inequities in hypertension treatment and control when we compare them to white people. Next. When we look at the economic indicators, as you see in this figure, we observe disparities of blood pressure control among many people who are disadvantaged regarding income, type of insurance, and level of education. Next slide. And when we look at subpopulations, look at this map, in almost 69% of counties in the US, heart disease mortality rates are actually increasing among people ages 35 to 64. And we are talking here about our caregivers, our workforce. Next slide. And we also see a worsening in disparities in CVD mortality depending on where people live, with higher mortality rates among those living in rural areas. So, next slide. Persons impacted by these inequities are shown here and include racial and ethnic minorities, pregnant and postpartum people with hypertension, people who live in rural areas or other access deserts, those with lower incomes, sub-insured, low-insured, and those with behavioral health issues who use tobacco. We need to promote and ensure health equity in cardiovascular disease prevention, and that means that everyone has a fair and just opportunity to attain the highest level of cardiovascular health. So how do we do that? Next slide. Million Hearts is a national initiative co-led by CDC and CMS. We are very excited because the initiative is going to launch next month in February, and we believe in the real possibility of averting 1 million preventable cardiovascular disease events in the next 5 years. And we do so by promoting a small set of evidence-based priorities and strategies that can improve cardiovascular health for all. And also by convening people like you who have the desire to collaborate, become champions in cardiovascular disease prevention, and are committed to addressing health equity through specific policies, processes, and practices. Next. So, Million Hearts 2027 is prioritizing CVD prevention strategies for building healthy communities and optimizing care through a committed focus on specific populations experiencing inequities. Next slide. For each priority, in this case building healthy communities, we have identified a set of strategies that when implemented in your communities can help us decrease tobacco use, physical inactivity, and particle pollution exposure in your communities. Next slide. Similarly, we have identified strategies for optimizing care to improve the ABCs, aspirin and anticoagulant use, blood pressure control, cholesterol management, smoking cessation, as well as increase the use of cardiac rehabilitation. Next slide. So the question is, how can the Million Hearts strategies be used to improve outcomes in these populations experiencing disparities in your communities? Double click. We know that hypertension is driving a lot of the disparity. So to improve hypertension control in Black or African American persons, we need to deliver medication therapy management, self-measured blood pressure or SMBP monitoring, and other hypertension management in trusted spaces like barber shops and salons, trusted spaces in your communities, as well as supporting policies that prohibit the sale of flavored tobacco products, usually targeting marketing to these communities. Click. We are focusing on hypertensive disorders of pregnancy by supporting widespread use of SMBP and expansion of Medicaid for SMBP monitors and medications. There's a theme here. SMBP works. We know it works. Click. We need to improve the access to cardiovascular health for people with lower incomes, and that can be done by supporting Medicaid expansion for SMBP monitors, medications, and cardiac rehab. Next, you could reach people who live in rural areas and access deserts by supporting access to virtual and remote models of cardiac rehab and support the use of SMBP and related telehealth needed for this to work. Next, supporting the expansion of barrier-free Medicaid for tobacco cessation can also improve the heart health of people with behavioral health issues who use tobacco. Click. So we've discussed the evidence we need to ensure health equity in preventing cardiovascular disease. We've shared the Million Hearts 2027 priorities and strategies, and now I want to encourage you to take action. Explore the CDC and the Million Hearts tools, protocols, and action guides that can be applied to your clinical setting. Next, visit the site in February next month to see the latest resources you can use to implement these strategies discussed today and stay engaged to learn ways to advance health equity in cardiovascular disease prevention. We seek strong and specific commitments to the Million Hearts priorities and strategies. We know, for example, that a 20% improvement in key indicators would translate to 1 million fewer events. And with your commitment, we know we can do it. Thank you. And at this time, I'm going to turn it over to Meg Mitter from NAC to introduce the other faculty presenting today, as well as the format for the call. Thanks.
Thank you so much, Fatima. As she said, I'm Meg Metter, Director of Clinical Integration and Education with the National Association of Community Health Centers, and we're very pleased to offer this Million Hearts Learning Lab to you today. Today's event is actually the third in a series of 5 mixed methods learning opportunities we have planned. This live webinar and Q&A will complete the full event, which also included an audio recording and a survey as pre-work for a total of 60 minutes, which is eligible for 1 CME credit. Don't worry, if you didn't have a chance to listen to those, the pre-work audio or complete the survey, you can still do that. There's a link on the screen, and it'll also be in the chat to our Confluence site, our Million Hearts website, or Million Hearts Learning Lab website, and you'll find everything there from past recordings to registration. Next slide. So here are today's learning objectives as we focus in on ensuring health equity and preventing cardiovascular disease. Importantly, as Judy and Fatima already emphasized, we want you to leave today's event feeling equipped with practical strategies and ways to assess and ensure health equity in your cardiovascular related care processes. Next slide. We have 4 excellent faculty for today's call who will be answering questions you submitted in advance, as well as those that come in through Q&A. You've already been introduced to Fatima and Judy from the CDC team, and joining them will be Dr. Commodore Menza, who has a joint appointment as assistant professor with the Johns Hopkins School of Nursing and Bloomberg School of Public Health, as well as Dr. Ron Yee, who is the chief medical officer at NAC. Ron and Yvonne, let me turn it over to you.
Thank you so much, Meg, and thank you so much to our audience for taking time to be here. What I'll do in the next couple of minutes is quickly recap the pre-audio recording. During my conversation with Ron, we talked about what we mean by health equity. And one of the things we highlighted is that we know that Black people are not at a disproportionately higher risk of cardiovascular disease because of their skin color, but because of underlying differences in social determinants of health, such as poor healthcare access, neighborhoods that don't enable them to live long and healthier lives, so conditions in which they live, play, learn, and work. That places them at a higher risk for cardiovascular disease. And we talked about a number of strategies to enhance equity. But one of the things I want to highlight before I turn it over to Ron is the importance of data, right? So there are a number of strategies that are listed on the slide, but each community health center or care delivery unit has to understand the data, clinical data, for instance, but also be able to conduct a social needs screening to really understand why patients are missing clinical visits, why blood pressure control is not achieved. Do patients who have limited transportation have a lower likelihood of achieving blood pressure control? So I want to stress the importance of data, but I'll turn it over to Ron, who will share some strategies that we can implement to improve hypertension control and advance cardiovascular health equity.
Thank you, Yvonne. And you know, as we think about summarizing the pre-recording, there were some key strategies that health center care teams really use to ensure equity in hypertension management and getting our patients under control. These really have to do with 3 areas, and I'm trying to combine these, and you can read these on the slide, but engagement, guidance, and follow-up seem to be the areas that health centers have really excelled in. We've learned in our Million Hearts learning communities that those health centers and care teams have made the biggest long-lasting impact on their patients. They do certain things. They engage their patients with uncontrolled or not yet diagnosed hypertension through improving access through expanded hours and telehealth. They establish protocols to help guide their clinicians that initiate and rapidly focus on medication intensification. And they guide their patients through if they have a lack of understanding or they have a non-adherence situation. They provide solutions like including and addressing cost barriers, like using low-cost generics, the 340B pharmacy program, single pill combinations, refill protocols, or using patient assistance programs. On top of that, they arrange consistent follow-up, and this is key to have that communication with patients. These are the health centers that offer solutions to bring their patients under improved blood pressure control and maintain that control over time. I think the care team aspect that health centers use is really key in working to align and coordinate these efforts and identify who will do what and to get our patients to good control and to good outcomes. So those are just some of the ideas from those few points at the beginning. And Yvonne, can you make comment about the other points included on this slide?
Yes, sure. One of the things I'd like to highlight is the importance of collaborative communication. So what does that mean? So it's important for us to demonstrate empathy in how we actually ask about adherence to treatment. So when we are, for instance, implementing the Prepare social needs screening tool, we need to ask the questions in a humanizing way that does not reinforce trauma. We need to actively listen to patients and not interrupt them. There are some shocking statistics about how long it takes for clinicians to interrupt patients. And we also need to engage them in shared decision making. So collaborating on what it means to achieve blood pressure control, how to set some goals and meet those goals. Another strategy that a lot of us have been talking about is SMBP, or self-measured blood pressure monitoring. But one of the things I'd like to stress is that SMBP alone is insufficient. Patients need more support. It's not enough to simply provide a blood pressure device. That's the first step. But patients need more support in the form of clinical support from the pharmacist or nurse or a community health worker to help them understand their condition and empower them to improve their blood pressure. And one thing I also want to highlight is that SMBP plus clinical support plus the integration of those blood pressure readings into the electronic health record would be the platinum version of SMBP. We need to make it easier to integrate these readings into the clinical workflow. And the last is, we know that as a result of the COVID-19 pandemic, there have been several disruptions in healthcare. But one of the highlights is that we've seen a rapid expansion in access to telehealth. So for patients who are missing clinical visits, we can identify opportunities to provide validated blood pressure measurement devices, offer clinical support, but use telehealth to offer more convenient options. So for patients who have difficulty getting sick leave, right? Or finding transportation or healthcare, to be able to make it in time for the visit, offering telehealth may help to overcome those challenges and improve access to timely care. And at this point, I already made earlier, which is using data, right? So we need to probe and interrogate the data and not assume that there are no disparities in treatment intensification, for instance. We need to explore the data to identify where disparities exist and use those data to drive the strategies that we implement. And the last thing I want to say is that multi-level interventions. So as you can see, there are a number of strategies listed on this slide, but multi-level interventions that address the multiple determinants are more effective than just identifying one determinant and implementing one strategy. And with that, I'll hand it back over to Meg, who will lead us in the next segment.
Thank you so much, Yvonne. Really, really great information. So for everyone, as we move into our Q&A portion of today's event, I want to remind you that we will be answering questions that were submitted through our pre-work survey. So thanks to all of you that took the time to do that. And we'll also be answering some additional questions as they come in if we have time from the Q&A feature. So please make sure that you open that Q&A feature. Our first question actually is to Ron, if that's okay. We can highlight on you. I wanted to pose a question about outreach strategies. So what are some outreach strategies that can be used to promote equitable care and let the community know that health centers are available to help?
Sure, Meg. So I mentioned some of the other ones prior that we did on the recording and were on the previous slide about the actual in health center actions and strategies. And I think going out and broadening that, I think a lot of it has to do with access, first of all, and then connection with the community. So I think the access piece, not only physically to telemedicine, but physical visits, but many health centers use transportation to really get out to their patients and to bring them in, or the telemedicine now to connect them. So I think accessing care is one big thing to level the playing field so that there's health equity. I think there's a lot of people shut in due to COVID. They're afraid to travel. So we look at that and we really work with that. I think the other one has to do internally with improving access to medications that we mentioned. And I think that is really key for our patients, especially that may not be able to get to that level of control because of that. Health centers do a lot of transportation, evening and weekend hours, also include the televisits. So I think that improves the access not only to care and contact, but to medications. I think the partners that we talk about in the field are health center examples, such great examples of them connecting with others to do community gardens that I mentioned in the podcast, job development, social services, and housing support. And this is how we really let the community know we're available, willing, and able to connect them to these services and partners to provide equitable care to the community.
Super. Thank you, Ron. Sort of a follow-on related question I will pose to Yvonne. How can I assure that my organization is addressing health equity, and how do I sustain these efforts?
That's an excellent question. And I'll go back to the point I made earlier about data, right? I think that one of the first steps is to make a commitment to understand where disparities exist and to advance health equity, but using the data to drive a lot of the decision making. I think we all can acknowledge that there are patient-related factors that prevent them from achieving blood pressure control, for instance, whether it's adherence, right? So that's one of the examples. But there are also clinician-related factors. So we know that there are instances where clinicians don't intensify treatment when it's necessary. So also identifying, are there disparities in treatment intensification? What can clinicians be doing on their part to improve blood pressure control? And in terms of sustainability, I think it will take all hands on deck, right? So once we have the data, how do we set specific targets and go back to the data to identify, have we made progress in 6 months, right? If there were racial and ethnic disparities in blood pressure control, has that gap narrowed? And narrowing does not mean white people doing worse than Black people. It's making sure that everyone achieves blood pressure control, but really always going back to the data to continue to sustain and improve those efforts.
Super. Thank you, Yvonne. You just remind me of how important the measures that we use in our Million Hearts Project. We use several process measures around medication intensification, looking at whether there are patients with uncontrolled hypertension on no therapy or on monotherapy. And I think those can be really powerful measures to help, sort of investigate what's happening with treatment and with disparities potentially. So I do have a third question here that I actually want to ask to Fatima first, and then would love to follow on and hear from you, Ron. This one is about social determinants of health. So how can individual providers address the social determinants of health? It's a very broad question, but where would you start?
Sure. So we know that social needs play a very crucial role in patient outcomes. So like Yvonne mentioned, we need to look at the clinical data, but understand the data in the context of social determinants of health. So before setting any strategy to address SDOH, what we need to do is assess the level of existing social need activities. So we do that by increasing our level of awareness. That means understanding and focusing on identifying the risks and the assets that each patient or population of patients have. Then we do that by adjusting, meaning that instead of addressing the social needs directly, we can, in our clinical practice, pursue a strategy that focuses on adjusting clinical care to address SDOH. That means, for example, offering translation services and understanding the cultural beliefs, the barriers, and the preferences of the patients and the communities. Another aspect that needs to be considered is assistance. We cannot do it alone. So strategies as simple as connecting patients with social needs to government and community resources and establishing linkages and communication pathways between healthcare and social services is absolutely critical. We keep talking about the crucial piece of partnerships in addressing SDOH. Then think about alignment. Again, we cannot do this alone. So providers can pursue an alignment strategy that assesses the social care assets in the community, then organize those assets to promote teamwork across different organizations, and later invest in assets that can impact cardiovascular health. And finally, think about advocacy. What do we do in the aspect of how can we form alliances with social care organizations that can advocate for policies that address SDOH? For example, calling for policy changes in the overall transportation services in a community can really benefit bringing our patients to our practices. Ron?
I was going to say, Fatima, thank you. This is amazing in terms of alliances, partnerships, and really thinking beyond the four walls of the health center. So, Ron, same question to you. It's how can individual providers address social determinants of health?
Sure, yeah. Fatima covered the area pretty well. I do want to emphasize, and this ties into what Yvonne shared about using data. I think we have so much as clinicians, we're not used to using certain data in our health systems, in our EHR, including those social determinants. Many times we're tied into the medical issues, and we need to take time to back up and look at the demographics of our patients that will inform us. What are those social determinant issues that are going to affect them carrying out our care plans, getting medications, showing up for visits? We have to find out if they're experiencing homelessness, if they're jobless, what their situations are at home. So I think we need to proactively look at that and then consciously think about how do I work those into my care plan? How does that affect them getting their medications? And so we think about those resources that Fatima mentioned in the community. How do we link them to that? So I think we're kind of like, since we're in football season, we're kind of like the quarterbacks. And we have to help organize and coordinate those functions and use our care teams and connections with the community to get them lined up, with food banks, transportation, education, job finding services. Those are the things that really round out our care and really help health centers, because we do whole person care, to round out that care and to consider all those elements that level the playing field, deal with health equity, but also put our patients in the best place to be successful of coming under good control for the hypertension and really avoiding those cardiovascular events that we mentioned at the very beginning. So I think we are the coordinators and quarterbacks of that care. And individually, we can think consciously about how does that affect our care and how do we optimize the opportunity for our patients to come under good control and to have good outcomes.
Thank you, Ron. Really appreciate both of your responses. And I do want to call people's attention to the Q&A. So one of my colleagues on our Million Hearts project with Ochin just posted an interesting resource that people might want to take a look at, related to social determinants of health and related to what Yvonne spoke about in terms of addressing patients in a very humanistic way. So they use something called I'm going to say this wrong, empathic inquiry. There you go. And she's actually posted a link there if you're interested in that. And it looks like it has roots in motivational interviewing. So thank you for that, Megan. Really appreciate that. Also want to take one question from the chat or the Q&A at this point. This is from Allison Smith. Are there any hypertension specific equity scorecards to evaluate health centers? And anyone can feel free to answer this one if you know of any. And if we don't, maybe there should be.
I don't know if there of one, and I don't know if it is as simple as Fatima was talking about looking at the data. where you really, in working with centers who have attempted to improve their blood pressure control, when they start looking at the blood pressure control by, and you can name the issue, but black, white, and see that they've made a 10% improvement in blood pressure control, except for in this population. That's not quite a scorecard, but that's exactly the data use that we're talking about. So many of the things that need to be done to improve cardiovascular care really need to be done for all. And as you look at the for all and what difference did it make, you may start seeing some. Somehow I muted myself, or somebody did. Whether it's differences in black, white, or differences in transportation ability, that's the piece where using the data makes some sense. So I'm not aware of a health equity scorecard, if you will, but always looking at your data to see that your outcomes are happening equitably, is I think what we'd be asking for.
Thanks, Judy. Do any others care to respond to that? Not, we can move on. We've got several other great questions. So this is a question from the pre-survey. The question is actually, how can remote patient monitoring be used to improve health equity? But I would also include with that, self-measured blood pressure monitoring. And that I'm going to ask Yvonne to answer.
So I think I touched on that briefly earlier in terms of how we can use SMBP. One of the challenges we know is that there aren't enough primary care clinicians to manage the burden of hypertension and other chronic diseases, right? So we know we need more clinical support for patients. And we also know that clinic hours are not convenient for some Americans who work a 9-to-5 job, and they may need weekend hours after 5 o'clock, right? So all of these options. So if we were to provide free, and I'm emphasis on free, especially for those who need it the most and have more modest means. And these devices are also, the readings are integrated into the EHR. That provides the flexibility and improves access to care so that clinicians can take action on those readings. So it's one thing for the readings to be transmitted, but it's another thing for a member of the healthcare team. So team-based care. It might not be the primary care clinician. It may be a nurse. It may be another member of the team to review those readings, right? And be able to reach out to the patient and have that bi-directional communication to address any concerns they may have. For instance, their medications, right? So sometimes when patients are not adherent to their medications, it's because of a lot of factors, whether it's running out of medications, side effects, but really having that positive feedback loop so that patients can see the impact of adherence on their blood pressure control, and for clinicians also empower them to really take control of their health. And the last thing I will say is there are already existing toolkits. So Million Hearts has an SMBP toolkit. Target BP has a toolkit. Allison Smith, I know, is on the call, but NACHC also has an SMBP toolkit. So these are all resources we can use to implement SMBP.
Really appreciate that. And I know, just to add on, one of the things we've learned in our projects and our work on SMBP is sometimes it's really not a one-size-fits-all approach. So really take the time to understand your patients using those social determinants of health screenings. Sometimes patients aren't really savvy with smartphones, and they may be better off with an option that's not Bluetooth based and maybe cellular based or manual even. I'm not promoting that necessarily, but the point is that you don't want to create additional disparities when you roll out an intervention like SMBP, because your patients may, for example, not prefer English as a first language. And so how are you going to address that to make sure you don't create additional disparities? So I just wanted to put that thought in there. Have another question. This one's for Fatima, and you mentioned this, I think, before a little bit in sort of the advocacy and the partnerships and the alliance that can be formed to address health equity. The question is, how can health centers engage in non-clinical partners in providing equitable care?
Thanks, Meg. I think we mentioned this a little bit before, about the importance of effective partnerships as essential for community-based solutions that can help us advance health equity, share our vision, our value, and increase the capacity of the community itself to shape the outcomes they want to achieve. And it needs to be done through fostering collaboration from multiple sectors. How do we do it? There are multiple partners that they can lead, participate, champion, implement solutions. I've said this before, we don't have to do this alone. You can let people know, the organizations know, the community know what the challenges you are facing in your practice are, what the goals, priorities, and strategies you want to use. I would suggest creating forums to bring cross-sector partners together. For example, combining professional education, joint conferences, social media, and invite the private sector and community-based organizations to these meetings to learn and to share their work and resources, because they may be working on those pieces as well. Think about faith-based organizations. Think about businesses. It doesn't matter if they're small or large. Think about barbershops and salons. Go to those organizations where people are living, playing, working, worshiping. Think about the education sector, education about the importance of physical activity and low sodium intake to prevent cardiovascular diseases. Think about academic institutions in your community. They have a key role on research, on education. Think about the philanthropy sector that can more easily deploy tools and resources to support communities directly. So think about the not so common agencies like housing, justice, planning, and land use, public safety, transportation. Each of these organizations, they can deploy unique skills and resources to different roles in community-based solutions for health equity and help you achieve your goals. Thanks.
Thank you, Fatima. I think that's, very wise advice that sometimes we think we have to take it all on ourselves. And really, when we share and expand the burden per se, it's really not a burden. We end up leveraging the best of what each of us all can offer. So really appreciate that. I do want to call out something that Holly posted in the Q&A. She was talking about how their organization talks to patients about social determinants of health, and it's a strategy that's worked well for them. She said, "We've been working to address social determinants of health needs in our severely hypertensive patients. We have tried a variety of approaches, but found that asking one broad question about social determinants of health and then quickly drilling down to each individual's needs has been very successful." So I just wanted to make sure people saw that comment. I thought it was helpful and useful information. So I do have a question I want to make sure we have time for Ron to answer. And this one's about care team members. So we've talked about outside the health center and really leveraging what's in the community. How can we leverage our care team? How can various care team members work together to provide equitable care and promote prevention?
Sure. Thanks, Megan. We've learned so much from our Million Hearts learning community. It's amazing. I think about them when I think of these kind of questions about teamwork and working together. And I think from our work, we've also would include clinical pharmacists. They've had a huge impact on what we do. But I think what we've seen, and I was thinking about our teams that have been involved, it seems like their care team management is threefold. So first one is they decide what's important to them. So what are those metrics? And using back to the data analytics, what are we going to set our systems up to determine if equitable care is being provided? What are we looking at? Do our patients have equal access to medications, services, education, preventive services, transportation? So to establish the metrics, number one. Two, I've seen these teams create the processes, protocols, and operational systems along with appropriate data reports to achieve those outcomes and to monitor themselves. Are we getting off track in process measures? Are we getting to the outcomes we need? So what's that creating the process, protocols, and systems to support those outcomes? And third, establish the care teams to do this. And we mentioned some specific people, but really when you get down to the health center level, it's who can do these roles and functions. It may be a medical assistant doing certain things. It may be a front office person. So the question is, when you look at the metrics and the outcomes you're looking for, who are the people that should be on the care team to accomplish that? And so what happens is you will use an existing team, or you may say we have a gap here and we need to hire somebody to do this, or transform somebody's position to cover this function. I think when I see these health center teams do this, deciding on the metrics and the outcomes, creating the processes and reporting to monitor those, and then who is it by the care team that's going to do this, those are the ones that have been very successful, and they have really brought good care of their patients and have the data to show where on the run charts they implemented certain things and where the changes came about in the outcomes. I think those are the centers that I love looking at as examples, and many on this call have done those. These are the elements that really help them to align and coordinate these efforts of our care team members and to provide equitable care and to promote prevention.
Thank you, Ron. I love the use of run charts too. I think it's a super valuable QI tool. We're running a little low on time, but I do want to ask two more questions. One is a follow-up that's in the Q&A from Nikisha, and she said this is a follow-up question to Judy's response on ensuring outcomes are happening equitably. Does this mean stratifying outcomes by race, ethnicity to evaluate this? You want to comment on that, Judy?
Sure, I would say I offered that as one of the things. Again, start with your data and see where your disparities are, and set your goal and your target, and then look to see if you're making those improvements.
Absolutely. And Judy, I have one final question to you today, and that is, I've heard of Million Hearts, but not sure how to become a part of this initiative. Can you share that information with me?
Sure. First of all, let me deputize you. You all are part of Million Hearts, having watched this webinar. In all seriousness, we need all of the foot soldiers out there working on the strategies that we've identified as the ones that can get us to 1 million fewer events. My suggestion would be cardiovascular health is broad, cardiovascular disease is broad, health inequities are huge. I would choose a focus area. Million Hearts is outlining a number of areas that are important to focus on and will have a big payoff nationally and locally. And so I would encourage you to choose an area to focus on, make a commitment, 5-year commitment to improve that by 20% would be awesome and would really make an impact. As far as more concrete, I encourage you to visit our website to see find some of the tools. You guys have seen a preview of Million Hearts 2027. The stuff is not live yet on the website until the end of February. So visit it now, visit it again in the end of February. Sign up for the e-newsletter to keep apprised of things like this Million Hearts Learning Lab and other resources that are out there in the community. And then I also would encourage you, as you've heard from a few of the other speakers, reach out within your community. There may be people working on Million Hearts. They may have an American Heart Association hat on, Target BP hat on, Department of Health, QIO. There are lots of people out there in our sort of broader community that might want to assist you in the efforts that you have.
Super, thank you, Judy. And I think we'll pivot to our final slides. We can, Alyssa. And speaking of resources, so absolutely the Million Hearts website is one of the #1 resources, and you'll see that there are some others that we wanted to share with you specifically today. You can find these, we will actually send the link so that you can access the slide deck and access the recording. So don't worry about trying to quickly copy and paste these. You will have access to these. So we do have a roadmap to improve blood pressure control for African Americans. We have some great videos. We have a new resource that's newly updated on choosing a home blood pressure monitor for your practice. We also have an opportunity to come together to talk about SMBP on a quarterly basis. This is a learning community, a collaborative community of practice to advance the uptake of SMBP. I saw lots of SMBP questions posed today, so I really encourage you to register and come and pose your questions there as well. And then we have a resource center on Prepare, which is our social determinants of health tool. So I'm going to turn it over at this point to Rupi Hayer from the American Medical Association. She's going to talk you through very quickly how to claim CME credit for this event.
Thank you, Meg. Hi, everyone. Thank you all for joining. So here are just a couple of steps that you'll have to take in order to get credit. Essentially, it's clicking on this activity page link, which is on our EdHub site. If you don't have an EdHub account, you will have to create one, which is pretty straightforward. But once you are in, there'll be a start button on the top right-hand corner, and it will actually ask you for a code, and that code is health equity. Once you enter that code, you'll be able to hit submit and take the quiz, and then claim your appropriate CME credit. Please note that credit is the deadline for claiming credit is March 2nd, so which is 45 days from today. And if we go to the next slide, this is just 2 steps on how to actually download your certificate of participation. So again, once you're logged in and you've done the quiz, you should be able to click on your name and select transcript, and from there be able to see the certificate button to download. And then next slide, and this is just a reminder of our next event, which is scheduled for March 16th. The registration link is here, which will also be sent in the email, and that one will focus on optimizing statin therapy for people with LDL over 190, specifically focusing on messaging and management.
Thank you so much, everybody. That concludes our event today. Really appreciate your time and your participation, and we'll see you next time. Thank you.